Ladies and gentlemen, dear colleagues, my name is Denis, and together with my colleague, Professor Hermann, we would like to present a new case from the ASAS Online Case Library. This is a bit unusual case. The patient is a 60 years old male patient who came to us with chronic low back pain with inflammatory characteristics, with slow onset, with pain at night, improvement with exercise, no improvement with rest, morning stiffness of more than 30 minutes for the last 5 months. All the symptoms appeared after severe viral respiratory infection, which was not specified. 3 years ago, patient had an episode of another immunological complication of a viral infection consistent with GPS. He had also back pain at this time point, which resolved over time without a sequel. The patient took an NSAID, Ibuprofen, but in insufficient dose, 600 milligrams per day, with some improvement, but not complete resolution of symptoms. He had no history of peripheral arthritis. There was some arthralgia, but no swollen joints, no enthesitis, no dactylitis. Also no extramusculoskeletal manifestations and no family history of inflammatory immune-mediated disorders. At the clinical examination, it was rather unremarkable. There was some tenderness over the sacroiliac joints on both sides, but no other musculoskeletal manifestations and no psoriasis. In the lab, we had slightly elevated C-reactive protein. It was even higher in the lab examination done by GP. HLA-B27 was positive, and there were no other pathological findings, especially no changes in the blood analysis, and we also performed immunofixation, which was unremarkable. So at this time point, we had a diagnostic challenge. So new onset of inflammatory back pain at age of 60 brings you a variety of differential diagnosis, and in order to identify the source of back pain in this case, some imaging was performed. So the patient brought already performed MRI of sacroiliac joints, and I would like to ask Kai to demonstrate the images.
Yes, and in fact, this patient came with these MRI images. So this was an MRI protocol suitable to image the pelvis. So that means the sacroiliac joints, but also the hip joints and the symphysis. So this is a coronal T1 weighted sequence. You can see the hip joint over here, the femoral heads. They look nice, and we see the sacroiliac joints over here, and you see the contour of the bone is nicely delineated. So already on the first slices, there's no suspicion of structural damage, and also we are able to see the symphysis here as the fifth joint of the pelvis. Then this image was complemented by a coronal stir sequence or coronal T2 weighted sequence. And we see that here's fat suppression applied. So we see the subcutaneous area is dark. We see the bone as a dark signal intensity area. And in these sequences, fluid shows up very bright. For instance, here, the fluid in the urine bladder or the prostate is rather high signal intensity, and we can see that there is high signal intensity at the posterior aspect of the pelvic ring. That means part of the iliac bone and also the sacral bone shows high signal intensity. And this is a symmetric manifestation. So both sacroiliac joint show some bone marrow edema. And it's not only bone marrow edema, you can see that also in the muscle, here in the erector spinous muscle, we have soft tissue edema adjacent to the contour of the bone. The third sequence that was provided is an axial slice. That means we see the pelvis. You see also the field of view is rather large. So it's not tailored just for the sacroiliac joint. So it's a sequence for the entire pelvis. And you see these bone marrow edema lesions here in the iliac bone, but also in the sacral bone over here. Also, there were sequences done for the lumbar spine. So it's a T1 weighted and a stir sequence. And you can see that these sequences are rather unremarkable. We see very nice nucleus pulposus signal, and also there's no disc protrusion whatsoever at the lumbar spine. So because this extreme pattern of bone marrow edema, which shows some very intense inflammatory process, we were rather concerned, also because of the age, and also we had some other patients in the past who at the end turned out to have some malignant underlying process or some severe form of enthesitis. So there's quite a range of differential diagnosis in this pattern. And we were interested to see if there's any bony destruction or any periosteal reaction. So we performed a low-dose CT of the pelvis, and this is the coronal reconstruction of this CT, and this is the oblique coronal reconstruction tailored for the sacroiliac joints. So looking closely at the pelvic bony structures over here, we can see that there's indeed no structural damage of the joint contours. They are looking really nice. We also see the facet joints which show a little bit of degeneration, but there's no destruction whatsoever. And if you compare the coronal CT and the coronal MRI, you can see that in these areas here, we do not see, in fact, any new bone formation in the soft tissues. Maybe a little bit, if you allow me to enlarge it a bit. So maybe there's some ossification over here, very, very faint, and this is more or less a ligament ossification. So it could be an entheseal ossification, but the patient has no psoriasis, so that is not an option. Psoriatic arthritis, which would definitely be possible, but maybe also the history of an underlying infectious diseases might lead to the assumption that there are some reactive arthritis. So, Denis, what did we do with the patient?
Yeah, so this imaging, especially the CT, was quite reassuring. It was important for us, as you mentioned, to rule out a dangerous diagnosis like an infection or malignancy. And based on the images we saw, we thought that the probability of immune-mediated disease of axial spondyloarthritis in this case is higher than the probability of any other pathology. Consequently, the patient switched an NSAID from Ibuprofen to a COX-2 selective inhibitor, Etoricoxib, and he improved really well. So he was doing quite well in the following months with quite low level of symptoms. And after 6 months, we performed a follow-up examination, both clinical and imaging, to see what has happened to those changes, massive inflammatory changes we observed initially, also to ensure that we're not missing something. Kai, if you...
So the patient then underwent MRI in our institution, and we performed a protocol that is suitable to image the sacroiliac joints and also the spine. So we have here now a imaging of the sacroiliac joint with a smaller field of view. You can see that still the joint contour looks very nice. There's no structural damage on both the sacroiliac joints. And we also have the stir sequence, which is in this setting of high importance. So we can see that the anterior part of both sacroiliac joints do not show any inflammation, which was also not the case in the baseline scan. And if we go to the posterior aspect, then we can see there is some bone marrow edema over here in the posterior aspect of the sacral bone. Also, you can see the ligamentous structure over here, and there's a little bit also of soft tissue edema, but the really extensive bone marrow edema is no longer visible in this patient. We performed a wipe sequence to confirm that no new erosions were developed, and also we had a look at the lumbar spine again to see if there's any inflammation going on in the vertebral bodies, which is not the case. There are some hemangiomas showing up here, and also the T1 looks rather unremarkable in this MRI examination.
So, as you saw, that was quite a rare case of really all late onset of inflammatory immune-mediated disease. Most likely, a severe viral infection induced the immune-mediated process in HLA-B27 positive subject, and that is why we saw this severe inflammation with severe enthesitis in a 60-year-old patient. Luckily, and we know it from reactive arthritis, those infection-triggered processes, infection-triggered autoimmunity, might be self-limiting. So we think that the natural course of the disease was the main contributor to the improvement of inflammation in this case, and with our NSAIDs, with the anti-inflammatory therapy, we just supported this process. So the prognosis in this case is rather favorable. We expect a complete resolution of inflammation and symptoms in this patient in the following months. Kai, do you see it often in your clinical practice, patients at an advanced age coming for the first time with inflammatory changes in the axial skeleton? What would be differential diagnosis?
So usually if patients come in this age group, there is some ongoing degenerative change, usually at the joints of the pelvis, especially the sacroiliac joints. But sometimes if there is, so in rare circumstances, we have new onset of axial spondyloarthritis, or maybe the disease was there going on for, let's say, 5 years, 8 years, and only at the later age it was diagnosed by certain circumstances, a GP, change of GP who was aware of the disease, or a new orthopedic surgeon who did know about the condition maybe. So there are some who are getting the diagnosis in an age like this patient, with age about 60 years of age. But usually you have to consider degenerative changes like osteoarthritis, like osteitis condensans, and also anatomic variants lead to osteoarthritis at the higher ages. So that is what we usually see. What we rarely see are any tumors. So if patients come from the rheumatology department, usually it's some sort of joint disease. Very rarely it is a surprising diagnosis of tumor or other destructive processes, and therefore, yeah, that's our experience with this kind of pattern.
Thank you very much, Kai, and dear colleagues. You can find all the differential diagnosis mentioned by Professor Hermann in the online case library. If you go and browse by the diagnosis, those important differential diagnoses will come up. Otherwise, we would like to wrap up this case. Thank you very much for watching and listening, and see you next time.
Bye-bye.